rheumatic repairs represented around 90% of the cases which we are doing. But today, I will tell you from statistics which we have got from the pediatrician, there has not been a single rheumatic heart disease case reported in Bangalore urban. However, Bangalore rural and the rest of Karnataka do have this thing. So we know from our pediatricians that it still exists. And it is reflected in our practice. What was 90% is still there. Around 60 to 70% of our cases still remain rheumatic, but they all are coming from the hinterland. So is it relevant? It's very much relevant. And this is what happened. We did actually a survey with the Cardiological Society of India, and even there we found that there is still a significant amount of rheumatic heart disease in rural India, and so this cannot be washed away. And the other thing is that the time lag of 20 to 20 years, which we would roughly say, is going to be there. So rheumatic heart disease is going to be there for us to stay, and so it's going to be there. Now, even now, 40% of the global RHD population still belongs to India. It's coming down relatively, but it's still there. And it's around 0.5 to 1.47 in different states. States like Kerala, where there's a tremendous reduction due to increase in this thing. And as I told you, even in Karnataka, we have seen zero. There has been no reported. It's a reportable disease, and it's not in Karnataka, and we have got zero in Bangalore city. But Bangalore rural we are getting, and other parts of Karnataka we are getting. But there is a trend, but so you're going to have a lot of variation. And we do get patients from all over India for repairs, and we are seeing this similar trend where urban people are not seeing the rheumatic heart disease, but still the large populace needs to be treated. Now, what is the results of repair? As I said, Carpenter's original work, then the current repair results are similar, roughly around the same. And you can say that at least for around 10 years that you would get good. And this could be vital, because today the mortality of redos have come down significantly. And if you can give rise to an anticoagulation-free survival life, it's significantly advantageous. Another thing that we've seen is that what is the 10-year survival with a mitral valve replacement? 60% is the claim. But one of my cardiologists was very diligent in this thing. He says that I ask a simple question: how many mitral valve replacements are there after 5 years? You must be doing a large volume, but see how many MVRs. You only see the successes, but you don't see the large number of deaths which occur. And if they're not following, they're dead. And the main advantage of doing a repair is that they can come back to you with a problem. They can come back with an MR. Whereas with a person who dies at home because of a choked valve or a intracranial bleed, he never come. I still remember when one of my colleagues who was doing replacement said, my patients have got good disease. I said, right now, do you realize that your patient is there being thrombolized? It took a lot of difficulty to convince people that you need to do it. And that's a fight which I have been doing for over 3 decades. And today I'm happy to say that my cardiologist, I now have a selection bias, which I was telling, that my cardiologist asked me, is this valve repairable? If this valve is repairable, go ahead and repair it. Otherwise, we'll delay for a replacement. So that's the thing that we have to build up our own clientele, and our job is to convince our cardiologists and our physicians. In fact, I was just telling my pediatric cardiologists are now talking of preservation of LV. Don't allow the LV to go into dysfunction. So they want me to do it earlier than late. So that's a paradigm shift which Carpenter had actually predicted that this was the ideal way of going about it. But then there is a lot of convincing that we have to do as surgeons. Now, what is the typical rheumatic fever? This is an old photo. This is a kid, and this is what you're going to see most of the time, that there will be some amount of AML prolapse, a significant amount of PML retraction, and there will be commissural fusion. This is one of the commonest things. So rheumatic heart disease repair requires a segment by segment analysis of P1, P2, P3, commissures, and A1, A2, A3. So it's very important. It's not going to be just an isolated P2 prolapse, which is something which I make my residents do, but you need to be able to analyze. So this comes with, and now I'm happy to say that my second rung can do these repairs very consistently. Now, how do we select? This is a common question that I say. Now, for a beginner, I would see we described, and unfortunately, this work was done by one of my cardiologist who was a PG at that time. He unfortunately died of an intracranial hemorrhage when he was a consultant, and we could never publish this. He had all the data and he did it, and somehow I never got to publish it. But this is the working thing which we follow in my hospital. His name was Dattatreya. He died. And we have described what is called as the infra-PML triangle. That is under the posterior leaflet. If you see it, is the arrow coming there? If you see the triangle which subtends between the PML, the posterior LV wall, and the caudal apparatus, and then we did 100 consecutive cases, and we followed up them over what would happen. Actually, it was 106 consecutive cases, and then he presented it in Indian Society of Echocardiography, and he won a prize actually for this. And we found that if the infra-PML triangle is greater than 1.5, the repair rate was 98%. This was at the beginning of my career. And if it was less than 1 centimeter, then the repair rate was 60%. And between 1 and 1.5 centimeters, somewhere around 85 to 90. Now, using this, we could sort of predict, and I will tell you now that my repair rate is much higher than this, but this was when I was a beginner, and that I should say should be translatable to people who are embarking on repair rate, that you should select a patient who has got a good infra-PML triangle, then you will be able to do it 98% of the time. Then as your skill set improves, you can start taking more and more difficult cases. Now, if you see the second one, you can see down here, you can see what should not be repaired, especially for a beginner. You find a calcified valve, you see a small infra-PML triangle, and extreme crowding. These are the sort of cases I would not recommend a beginner to do. Even I would be circumspect for doing such a case, but it depends. See, the push is if it's a young patient, a lady who wants to get pregnant, this thing like that, you would push and try to do a repair in more complicated cases. Whereas if she's finished her family, is more elderly, this thing and that, then you would have to choose, and that's where decision making becomes important. Now, if you were to talk about it, I would always divide it into the bad PML. Now, retraction is typically the P2 or P2, P1, P2, P3 is retracted. And the first step that I always say is divide the posterior basal cardia. This immediately makes the leaflet more pliable and allows it to do. Then you have to do a good OMV. When I started my repair, I had not even seen repair being done. The only repairs were for things like congenital MR, like cleft AML, like that. Otherwise, there were no repairs being done when I had not, but all I knew how to do was a good OMV. And trust me, that was the one thing that helped me do a lot of repair. If you need to release the hinge point, and you need to do first a good OMV and good release of subvalvular apparatus. Once that is done and release the posterior basal cardia, you convert pure MSMR. Very commonly there is MSMR. Even sometimes 1 to 2 millimeters a cut may be required because the hinge has to move. The door moves around the hinge, and if you don't release the hinge, you will have a residual gradient. And so this is a thing which I said. There are three. What are the strategies? Either you divide the posterior basal cardia so that it roundens up the flat thing, or else you pull it, or you patch it. And another thing which I call as a veil. Each one depends upon how bad the PML is retracted. And if it is a focal retraction, you can just close the pseudoclefts, and I'm using that less and less nowadays. But what I do is a contralateral tethering stitch. I think I'll be putting it. This was described by Kalongas, but I was actually using this much. This is what we tell now. We are lazy and we don't publish, and that's our problem. And I was using it for decades, and then I suddenly realized Kalongas published it. Fault is ours. And then the next is a local or a pericardial prosthetic veil. So this is a Kalongas stitch where many times you do a repair and you find a small focal leak, irritating focal leak. You just put a pledgeted, you get this VSD sutures, 4 Ethibond with the pledget. You pass it from the area of the PML and you hitch it to the anterior part of the ring. And this is an example of a ring which I used to make in the olden days, the old slide. And you can see that that irritating leak will go away, and it will allow you, and trust me, I always tell the difference between having a repair rate of 70 and going to 98 to 100% is eliminating these small things, what I call as nips and tucks. That's what makes the difference. So, and so you can, here you can see, I have taken, I have closed this cleft, and then I have to, actually you can see, I have put a contralateral tethering stitch, and you can see the excellent coaptation that occurs. Now, if there is a focal retraction, then I call it a local veil. Oh, sorry. So if there are, in rheumatic repairs, you may have crusts and troughs which are irritating on the PML. It's a rugged surface, so you can smoothen out that by putting, I mean, in this patient, I put a Gore-Tex membrane, but many times I put this thing. Now, if you have a, you can put, you can augment the PML, but trust me, one of my colleagues who was trained under me does a lot of this, but I usually say that if you need to augment, usually there's something wrong, and you are just shifting the irregular surface a little down. But one of the key points that I tell is that you need to, if you're augmenting, you need to put a massive level of augmentation. So don't put too less. Don't worry about SAM. Rheumatic has never get SAM. So augment and augment well. In fact, the patch should be nearly as big as a sizer of that size. Okay. And another thing which I have done, and this especially I have done in kids, is that I have placed a ring, and then what you see here is actually an entire artificial PML, which has been made with pericardium, so that now you can see that when you coapt, you will get competence. The push to do a repair in a kid is so high, but surprisingly, I found extremely good long-term results with this. And though even I don't do this very often, but paradoxically, sometimes I think I have to revisit this, because this seems to be giving, and fusion is impossible. Re-MS is impossible with this method, because they are having something into it. And it's something which even I have to explore doing more. And this is, for example, a total, this is a 4-year-old child with rheumatic heart disease. What are you going to do for this? The push was so much. And in such cases, you can see I have actually not been able to put a ring, but this child was put with a totally artificial, that's a totally a veiled, there's a veil over the existing PML, and we got a very good orifice area. It looks terrible, but it's functional. And I have not replaced this child. He's gone into adulthood, and I have not replaced this child so far. So we need to have out of the box thinking. And just incidentally, if you can see, this annuloplasty was all done with a pacemaker wire. I used to use a epicardial wire as an annuloplasty thing at one time. So now the next thing is for AML prolapse. The common thing was to use Gore-Tex, and initially I used to use what Tyrone David describes as loop over loop technique. Problem for us is, in a teaching institute, Gore-Tex cordae are expensive. If I were to use more Gore-Tex cordae, they would tell me don't repair if the cost is going to become. So I had to start trying things, how to reduce and the problem with loop over loop technique is I could do it. It was a little painful for me also, but it has to be transferable to the next generation. So then I realized that this is not very good. So this is what I do, which I called as combined cordoplasty. And I will see, when I started doing, no internet, nothing, all of us, the seniors, there was nothing there available. I had only Carpenter's French correction article with me. When I used to do the repair, I used to sit, read it, and then do it. Then again, read it and do it. Every time I used to read the article, and then I used to go in and repair. So then he had abandoned doing trenched cordoplasty because the suture would rub and cause the cordae to tear. I said, then let's eliminate that. And I started doing it. And you can see here, we shorten the cordae by using the Gore-Tex cordae. But the most important thing is no trench. The other thing that I do is I use the same Gore-Tex cordae and make it into a strut cord. So now it deflects the tension across all the cordae that you are having, because the strut cordae is one which is going to decrease this thing. So this ended up with, actually now I've been using it for more than 3 decades now, 3 decades of repair work. And trust me, this is the stablest part of the repair. The nemesis is P3 in rheumatic heart disease repairs. P3 retracts. So actually I tend to put a contralateral tethering stitch many times. in P3, if I find any fibrosis in that areas, because I know that in the long term, failures, there are two types of failures: stenotic failure, which some of them have been reballooned by my thing, and then regurgitant failures. Regurgitant failures are primarily P3 retraction. There is one more type, which is where AML is retracted, that no one can do anything, because that represents typically patients who don't continue their rheumatic prophylaxis. But if you fix your P3 tight, it can't retract, and that's one way of eliminating. And those are the patients who actually got good long-term results. So you can see this is the way we do it. So what can be achieved? Progressively with experience, you can do calcified valve. You can see here, for example, I've actually removed a piece of calcium. I have patched. I've done all sorts of things. So you can get all these things. Now, we have done, now we just analyzed the data some time back, and 80% of the data over the years from 1997 to 2022, 80% were rheumatic heart disease, because primarily in the initial phase, most of my repair work was rheumatic. And in 2104 mitral valve repairs, see, there is a bias in the sense, I don't know how many went to Saint elsewhere. But we've done personally, we had to do 34 redo replacement, were all rheumatics, 5 redo replacements, and this thing. So we are analyzing our data. And as far as myxomatous valve repairs, one small point for P2 prolapse, please don't use Prolene, because we had perforations, 2 cases, and we abandoned using Prolene and we use either Ethima. We are getting Cardionil, you use Cardionil if it is available, or Ethibond, 4O Ethibond is what I use. But where do we get redo replacements? Have all been essentially in rheumatic. And then another thing is follow-up is very important because of endocarditis. So is it worth it? See, this was a boy who had operated today he has come. He was a school student when he came. Now he has come with his wife. And now he's actually, the later thing is that unfortunately I have not taken the photograph of him bringing his child. Would he have survived to be able to this thing? I had a rheumatic double valve repair. I had to do Azaki plus mitral valve repair last week. Unfortunately, the repair failed and I had to do a DVR. I said, I've sentenced this child to death. She will not become an adult. I was so upset. Whereas, see this, he can come back to me. And I said, I literally say a DVR in a young kid, not going to see 18 years. Let's be honest. So another thing which I have been doing is, you can tell me to stop if my time is out. Another problem that we face with rheumatic heart disease, this is one thing very dear to my heart, is that what to do with patients with severe RV dysfunction, because we have burnt, I think every one of us have burnt, the patient comes off bypass, starts getting progressively, RV liver enzymes go up, then around the 7th or 8th day goes into hepatorenal failure and then dies. So very common. This was what I used to face. And so it was very difficult. And then what was the thing? So we did a study, and then with patients with RV dysfunction, we just started to follow up these sort of patients, and then we found 2 things which we noticed that patients who had a TAPC less than 10 were the ones who were dying. So we wanted to analyze how things were, and in the meanwhile, another thing that I was doing is I started noticing that these patients who were dying of hepatorenal failure, typically between 6 and 7 days, they go into SIRS. We noticed that these patients, I was struggling with sort of these patients as a young surgeon. And I noticed that I was I had learned echocardiography myself, because I used to beg cardiology, come do my haath paung jod ke, I used to ask, come do my echo, come do my echo. Very difficult. So I said, I quit begging and do my own echo. So I started putting the ultrasound probe onto the liver, because they're developing this thing, whether what is happening. And I started noticing that there were no hepatic arterial Doppler, this thing was not there. I had to learn how to probe the, how to image the hepatic artery, and I found. Then one day what happened is I had a patient whom I had put an IABP out of desperation, trying to do something to save the patient. And I had some amount of limb ischemia. So I started giving intraarterial nitroglycerin through the central lumen of the IABP. And then I see this patient's trying to see where is the thing, what is happening. And I started noticing that the hepatic arterial flow started coming back. That made me think. Then I gave sublingual nitroglycerin, didn't work. IV nitroglycerin didn't work, but intraarterial through the central lumen of the IABP was working. So then I sat and did the study on this, and we actually published it and showed that and there is a scientific basis to it, because in patients with chronic venous congestion, the hepatic arterial flow overtakes the portal flow as a nutritive flow for the thing. And when you go on bypass and the hepatic artery goes into vasospasm, we showed that this vasospasm lasts for 72 hours. So you get progressive ischemic hepatitis over a period of time, despite having good BP, everything afterward. And then they go into the SIRS-like state. We actually wanted to work further and try to measure endotoxin levels, because I thought that SIRS that happens there is due to endotoxin release through the gut, but we never could do that. It was difficult. So between 2009 and 2030, we followed up 456 patients with severe TR and with RV dysfunction with TAPSI less than 14. Always 6 cases. And when we saw that, you can see that patients who had a PA pressure less than 50 and who had a TAPSI less than 10, 9 out of 9 died. We had 0 survivors in those. So I presented this in the Brno Symposium in Croatia, and there we had a big discussion on this. And so in this thing, if the TAPSI is less than 10 and the PA pressure is normal, we don't offer surgery, because I say this is significant end-stage heart disease, and these patients should probably go for transplant pathway or VAD, whatever you want to do, but they will not survive. But whereas if you see here, even though they had TAPSI less than 10, if the PA pressure is high, they will, as long as the PA pressure falls. So just see that they don't have some COPD or something like that. I would like to add as a qualifier. And so don't take such patients if you have COPD, high PA pressure, which you don't think that is going to, but if their PA pressure is going to come down, that is, you don't have other pulmonary cause of this thing, they do very well. I mean, don't think of mitral valve disease, lung laden with fluid type of respiratory issues. So these were the lessons I learned, and with this we have been able to significantly offer surgery to a large populace and over the years. And in fact, many of my references now come for patients with bad livers, specifically with the cardiologist asking, can you do it? We offer surgery for childs A and B, but not for C. C should get liver transplantation. The mortality will be too high. I mean, I don't think, and even if you were to repair them, you're not going to do well. They should go for heart liver, or repair the heart and go for liver transplantation. But A and B, we significantly reduce the mortality with such an approach. So those are the pointers. Is it, and so to end it, is rheumatic heart disease relevant in India? Yes, it is. There is still a large population. If you are not getting them in your practice, especially in private practice, I know, because there will be people going, that means to say you are not attending to that practice. But if you offer it with better income, all those patients as they come up, you will get for the next 10, 15 years till India progresses in its economic, we are going to have to attend to all these patients. Thank you.